So I'll get started on just some of the housekeeping as we finish up letting people in. All right, so welcome to the Georgian Fahey Center for Healthcare Innovations 2023-24 Patient Engagement Lunchtime Learning Series. This series is accredited by the Royal College of Physicians and Surgeons of Canada as a group learning activity, and it may also be eligible for credits towards requirements of other professional bodies, such as the College of Pharmacists of Manitoba and the College of Registered Nurses of Manitoba. Please note that for the lecture portion of this session, participants will be force muted and video turned off. We will re-enable this feature during the question period. The chat will also be restricted to sending messages only to myself as the host or the co-hosts only. To use the chat box in full screen, click the chat button at the bottom of your screen and then proceed to where it says type message here, where you can write in your response. If you have any trouble with Zoom, please feel free to message me directly at any time. We also have auto transcription enabled, so you should see closed captioning for this session. If you want to toggle this on or off at any time, you can do so using the captions button at the bottom of your screen. For today's session, we will learn about patient and community engagement of sexual and gender minorities for research leading to health policy change. For this session, we welcome Dr. Murdoch Elias, who is an organ donation, critical care medicine, and emergency medicine specialist physician. Trained as a clinical investigator, he serves as the Director of Research for the Department of Emergency Medicine at the University of Manitoba. Dr. Elias extends his commitment to the principles of equity, diversity, decolonization, and inclusion, or EDDI, through academic and clinical services as Director of EDDI for the Canadian Critical Care Society. Welcome, Dr. Elias, and please go ahead whenever you are ready.
Thank you so much, Victoria. Thank you for having me. I'm going to share my slides here. So I appreciate the opportunity to speak to everybody today. I know we've got a diverse audience, people who've got different backgrounds in this field. And so I hope we'll talk about something that'll be interesting to all of you. My name is Murdoch Elias. I use he, him pronouns. I wanted to just begin with a territories acknowledgement. So the University of Manitoba, where I'm speaking to you from, campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So today, have a few general objectives. I'd like to present to you a patient-oriented research program that focuses on health policy revision. This is the program of research that I'm leading. And also provide a bit of an overview of a patient-oriented research and patient engagement framework specific to engaging with equity-denied or equity-deserving populations. And then I'd like to discuss health policy revision as a research program goal. So we're going to frame the discussion today around this research program. And so I lead a research program focused on sexual orientation and gender identity in organ and tissue donation and transplantation, or OTDT. You may hear the acronym. I'll tell you more about that program. But as mentioned, I was trained as a physician and as a clinician investigator. And so I have a background in clinical epidemiology. And really, to start this research program, it was born out of my clinical experience through my work in the organ donation system. I realized that our health system structurally supports practices and policies that really could be revised and updated to improve inclusion and to enhance equity for a number of different groups. These issues, intersect with differences in access to health services based on race, based on gender identity, based on sexual orientation, geography, socioeconomic status, as well as levels of education and health literacy. As mentioned, I'm very active in advocacy work with the Canadian Association of Emergency Physicians, the Canadian Critical Care Society, and the Canadian Society of Transplantation, which are national allied health and physician specialty organizations in the fields that I work. So just a little bit of background to hopefully make sure that we're all sharing a common mental framework in approaching the topic today. SOGI, or sexual orientation and gender identity diverse folks, and there's many different umbrella terms, but I'm going to use this one for now, make up 10% of the global population. I think we know from large surveys, of multinational surveys, that this is around the average, and this is probably an underestimate because these are people who are willing to identify as SOGI diverse, or able to identify as SOGI diverse. And we know that with younger generations, increasing proportions of younger generations are identifying as a member of this community. Really broad strokes, it's important to remember that gender identity and sexual orientation or attraction are distinct concepts. They interact, they're related, but they're not the same thing. And really that means that SOGI diverse people, or 2S LGBTQIA plus people, or queer people, are not a homogenous group. This is a heterogeneous group. There's people of all walks of life, all kinds of intersecting other social identities captured when you talk about this group as a group. And these identities, these lifestyles, the different lived experiences that people have, they position individuals to experience advantages or disadvantages. And there's a spectrum of privilege and power even within systemically oppressed or marginalized groups. To give you a little bit of background around some of the issues, because a lot of people aren't familiar with organ and tissue donation and transplantation, policy and how the system works. I thought I would present at the beginning here. This is part of a public-facing call to action that members of our team published. It was focused on Canadian health policy specifically, but it highlights some of the potential or the real inequities in the system, some of the issues that we're going to talk about. And so I'm going to just use this to present an introduction to those as we get into talking about engagement. So for organ and tissue donation for queer people in Canada, there are different rules and policies that exist, and some of these lead to inequities. So if we consider solid organ donation, and that's donating things like your heart, your lungs, your kidneys, your liver, and your pancreas, this is donation that happens after somebody dies, or in some cases, people are able to be living organ donors and donate a kidney or a piece of their liver. And so in the current regulatory framework, male organ donors who have had sex with another man in the last year cannot donate their organs except through an exceptional distribution process. And that means their organs are labeled as being at higher risk for HIV and other infectious diseases purely because they've had sexual contact with another man. When we talk about tissues, and those are things like donating your corneas to help restore sight, bones, skin, other tissue are also donated and can be used to make tissue products. The system is even a little bit more restrictive. And so in Canada, it's legal for men who have sex with men to donate tissues and organs, but in practice, tissues are rejected by tissue banks across Canada without even being tested for HIV, as there's no exceptional distribution process for tissues, unlike organs. And so functionally, men who have sex with men or women who have sex with men who have sex with men are disqualified from donating tissues. There's also a issue with stigmatization of donors, and they're labeled as being at increased infectious risk. So if you're a man who's had sex with a man, you're labeled as being increased infectious risk to transmit HIV or hepatitis inadvertently through donation. And that's, purported to be a behavioral criteria, men who have had sex with men. But really functionally, this stigmatizes unnecessarily a large population of men who have sex with men who are not at increased risk of having an inadvertent HIV or viral hepatitis transmission to a recipient. And so when it comes to tissue donation, functionally, queer men are routinely rejected. And I'm using the word men here, but in practice, our system also has really limited ability to interface with people who have non-normative gender identities. And so the way that these rules and policies are applied to folks who are trans or gender diverse are even more murky. And these identities are really not addressed in our system. And so these folks are not able to donate their tissues. The policy in Canada is 12 months. Any sexual contact within that period puts you at increased risk. But in practice, actually, a lot of tissue banks follow US policy. And that's because they get their accreditation through a US body. And so they take even a more strict approach than the health regulations require. And many tissue banks will reject tissues if a man has had sex with a man in the last 5 years. The increased risk designation is really core to some of the inequities that exist in the system, but there are other issues. And another one that we've identified was the risk of inadvertent outing and insufficient privacy protections for patients. So as a part of this system, if you are labeled as having an increased infectious risk through donation, the potential recipient of an organ or tissue, there are organs that are listed as increased infectious risk, has to be told that the organ they're being offered comes from a donor who had behaviors that could increase their risk of passing on HIV or hepatitis. And in the case of living donation, very commonly living donors are known to the potential recipient. And so they come to the program together. Sometimes these are people within families. And there has been insufficient consideration of protecting the identity of potential living donors who are being worked up through this disclosure. So there's the risk of inadvertently outing somebody who comes to be a living donor. There are also issues in the system that are concerning, stigmatizing. Our current recommendations from the Canadian Standards Association recommend that as part of the workup of a deceased donor, that they should all have screening rectal exams to identify evidence of receptive anal sex. And if identified, that would indicate that that person is increased infectious risk because you would assume that they are a man who's had sex with men. This recommendation is not evidence-based. It's really based on discriminatory and stigmatizing ideas about and assumptions about the sex lives of men who have sex with men, and is unfortunately still appears in our official recommendations for how to work up a deceased male donor to see if they qualify for donation. Data collection in general, I mentioned, are issues with being able to interface with diverse gender identities, but really there's incomplete data collection. We'll talk a little bit more about this throughout the system. Sexual orientation, gender identity are not captured. Many other social identities also are not adequately or ideally collected through our health system. And so our ability to monitor inequities and evaluate them is limited. There are also issues with sex-based calculations in clinical care. And so some of the ways that we evaluate, let's say, patients' kidney function, for example, there are equations and formulas that we use where there's modifications for sex, but it's uncertain how these modifications perform in patients who are transgender or gender diverse, on or off gender-affirming hormone therapy. And so these patients are particularly at risk to have rules or cutoffs potentially misapplied. And tying into the increased infectious risk designation is really the issue with HIV stigma. And so similar to queer populations being stigmatized, there are still policies in place that have not yet been updated to reflect the current paradigm around HIV detection, prevention, and treatment. And we know now there are highly effective therapies to prevent transmission of HIV through sexual contact. And our current system doesn't account for these. And so not only are queer populations stigmatized, but also people who are living with HIV, or serodiscordant partners of people who are living with HIV. And so these people would also be considered at increased infectious risk for having sex with their partner who's living with HIV, even if there have been risk mitigation strategies in place where statistically there's a 0% risk of that person having HIV. So that's a little bit of background to kind of frame the discussion, but I'll tell you now about the research program and a little bit about what work we've done and the work that we're doing with a focus on our engagement strategy. And so at the start of this research program, after identifying these issues in practice, we started with some structured literature searching and developed a collaborative team. And so these include content and methodologic experts, as well as stakeholders in the system. And it was really important to me that patients with queer identities and lived experience were at the core of this research program. And so we started planning for patient engagement early on, which requires funding, and we'll talk more about that. So at the very beginning of our research program, we formed a patient and caregiver advisory team. And so this team is composed of people who have lived experience of the organ and tissue donation and transplantation system, either as living donors themselves, as the caregivers of deceased donors, or as transplant recipients. And these people also all have queer identities. And so we formed this group and regularly, met with them to help guide our priorities, to form the questions that we wanted to ask. And they've been involved in all of the projects that we've completed so far. And so I would say we started with a bit of a discovery phase, scoping review and a systematic review to understand the existing issues that have been published, as well as a data scan looking at the sociodemographics that are collected and other types of data collection processes in our organ donation organizations across Canada. And simultaneously published a policy critique that was public facing and directed at our stakeholders to identify some of these issues. And this has led to further work that's underway with some observational work looking at existing health administrative data sets and some retrospective chart reviews. We're just in the writing phase of a project where we did in-depth interviews with our advisory team, really to follow up on a recently published scoping review that identified published issues to get into much more detail of people who really have lived experience, what issues they're facing, and what their priorities are, what the impact of these different inequities in the system are. We've got a Canadian national public survey that's going out in 2 phases, as well as a Canadian national survey of healthcare workers in the system to understand their current practices, their beliefs, their opinions about different important factors, as well as an economic evaluation and an epidemiologic risk modeling analysis to understand what the residual risk of an unintended infection with HIV or viral hepatitis through the donation system would be under different policy alternatives. And I'm just going to make a quick plug for one of these surveys, which is a form of engagement. So we've got a module in the Sex Now survey that's out now, collecting data. So if you are a queer person in Canada, please complete the survey. If you haven't, you can Google Sex Now. This is a survey that's put up at the Community-Based Research Center, or CBRC. And it is currently active, and it asks about lots of different healthcare experiences, but particularly we've got a module on organ donation and transplantation in this survey, and we're really excited to see what the Canadian public thinks. And this work is leading to a national consensus process. And so this is going to be a consensus process of all of the key stakeholders in organ and tissue donation and transplantation in Canada. So the research, the physician specialty organizations, the research organizations, and the health service delivery organizations that actually administer and regulate the system. We're going to update recommendations on the use of donors who potentially have an increased risk of transmitting an infection through donation. And there are other interventions that are also concomitantly underway that include a training curriculum on queer health and cultural humility for healthcare workers in organ and tissue donation and transplantation. So that's a lot of talking about the research program. And now I want to focus a little bit more about the patient and community engagement approach. Um, I appreciate, again, we're coming from diverse backgrounds. And so some folks will already have a lot of experience in knowing, especially about the basics of patient and community engagement. So I thought I would just highlight briefly, we've got a Society for Patient-Oriented Research definition of what patient-oriented research is, and it's research that engages patients as partners, that focuses on patient-identified priorities, that improves patient outcomes, that's conducted by multidisciplinary teams in partnership with relevant stakeholders, and that aims to apply the knowledge generated to improve healthcare systems and practices. And so this is research that's carried out with or by members of the public or patients, rather than about them or for them or to them. And it really is about engaging with people, their caregivers, formal or informal, not the healthcare team, but people who care for patients in the community, as well as communities who have lived experience of a health issue, and ensuring that they have a say in decision-making about the research progress. So the goal is, co-production and co-development of knowledge. So considering engaging with equity-deserving populations or equity-denied populations, we have to understand and have, I think, a shared definition of health equity. I know for clinicians, of course, this has been in the the cultural zeitgeist a lot more in the last few years, but there can still be uncertainty around what equity means versus concepts like equality. So I thought I would just take a second to really underscore that health equity is the absence of avoidable or modifiable differences in health among populations or groups defined socially, economically, or geographically. Health inequities are measurable, and they differ due to underlying levels of social advantage and power. And they're associated with consistent patterns across the population, and we consider them to be unfair. And so really importantly, equality and equity are not the same thing. So under an equality framework, you can see these figures on the left of the screen. It's a very simple graphic. But if the health outcome is reaching an apple on the tree, people have different heights to start with, and so different abilities to reach that health outcome. And under an equality approach, everybody is given an equal advantage, regardless of where they start. And so some folks didn't even need the advantage to reach that health outcome. Others are still unable to reach their health outcome with that advantage. Health equity could be considered an ideal state where all people are able to reach their full health potential, regardless of where they live, who they are, what they have. And it seems like a simple concept, but it does come up over and over. And so I thought that was worth mentioning. So equal care should really not be confused with equitable care. When we start engaging with an equity-deserving population, I think at the very onset, it's really critical to take a reflexive approach and to consider our positionality as researchers or academics. And so that is the social and political context that creates your identity and how your identity influences and biases your perceptions of the world or your outlook on the world. And even if you are yourself a member of an equity-deserving patient population, and the same population maybe that you're seeking to engage with, you're still a member of other institutions of power that may differ from other members of that community. And so, if you're involved with health services delivery as a clinician, if you're a member of a university or an academic institution, then you have a different perspective that contains privilege and power from those institutions and structures that your patients or the subjects of your research or the partners in your research may not share. So I'm going to speed through, I think, these next few slides. It's just as a bit of an overview of a framework for planning for engagement with equity as a consideration. And there's a nice little graphic here that I'm going to use to kind of center the discussion. It's from the Ontario Health Equity and Engagement Framework. This is a Googleable free resource. And if you're thinking of planning for your own engagement, I think it's a nice handy way to frame the conversation. So they put forth a 6-stage planning and engagement cycle. And this graphic covers the high-level steps that are involved in the proposed engagement process. And it's represented as a cycle intentionally because it's ongoing and iterative. And so we'll just quickly touch on each of the steps. So at the beginning of your engagement, you need to articulate a clear purpose. And it's important to define the purpose of engagement, to identify health inequities that may exist, and to maximize, the research and the data that you have available to identify those in advance. Um, Important to prioritize which population specifically you're looking to engage with, and understand who is marginalized, and who needs to have their issues addressed in whatever context you're looking at, as well as developing preliminary goals of engagement. So by the end of step one, you're trying to understand which potential marginalized population you might want to engage with, as well as the preliminary goals. And so this is sort of an initial planning phase. Step two requires or includes planning collaboratively with your partners. And so some of the questions that you might ask at this stage are, who are the potential partners? Do we have the right partnerships that we need? Is everybody at the table? What voices are represented? What voices are missing? And how to then refine the preliminary goals that were set to meet the needs of the partners with this more in-depth feedback from patients and communities. What is your capacity to work with the interested partners, and what do they need from the research team, or what opportunities are there to build value with that relationship? And so at the end of step two, you've started to garner buy-in from partners and a shared understanding of the engagement purpose and the objectives and the outcome that's intended for your engagement. Step three, develop an engagement approach. And so some of the questions to consider in this step are, what are the agreed upon objectives of engagement? How is the engagement specifically going to be conducted? Through what form? And we'll talk about some different considerations in the next few slides. What are the specific needs of the equity deserving population? Who's going to conduct and lead the engagement exactly, and where and when it will take place? How do the sessions run? What materials are needed? And so by the end of step three here, you've developed a clear approach for engagement. And before we continue on, there are some of the other things that you might want to consider when planning for engagement with equity deserving populations. What are the barriers to people engaging with you? And so this is going to be very contextual to your individual research programs. So won't be able to identify all of the specific barriers you might have, but some general principles would be to consider, what population you've got, what their level of health literacy is, previous negative healthcare experiences that the population may have, and how that could lead to trauma and mistrust of institutions and of health systems. There are many different competing demands that folks have that would limit their ability to engage with you and your research. So thinking and planning for these things, like what caregiver responsibilities folks have, people who have inflexible or unpredictable employment schedules, if they have other household responsibilities, or if there are barriers in accessing transportation. If people are facing unstable housing or food insecurity, engaging in research is the very bottom of their list of their priorities. So basic survival may be a higher priority than engagement in your research, and particularly with equity deserving populations who disproportionately face inequities, these issues are amplified. And so they really, I think, warrant specific consideration and advanced planning. Also important to consider budgeting for engagement. So, in health research, I think this is well accepted now in our field, but bears mentioning, we receive a benefit from the patients who are bringing their lived experience to the table, or from the communities that we're engaging with. And the institutions that employ us get a benefit through their engagement, and people really need to be compensated for contributing their time and effort to research, and granting agencies recognize the need to include these items in funding applications, but they do need to be planned for in advance. Expecting that people will be able to volunteer their time for free is going to lead to really limited, I think, opportunities for authentic and meaningful engagement. So, think longitudinally when budgeting for engagement. You are starting, through costs that might be related to recruitment, planning for things like education, training, mentorship, experience, depending on the engagement framework that you ultimately choose, the engagement process itself, and then subsequent knowledge translation and dissemination, all require planning and budget support. So it's important to think of that ahead of time. All right, so back to our cycle of engagement here. So step 4, conduct the engagement exercise itself. And so some of the questions at this stage are, what are the findings? What verbal or nonverbal information is being provided by participants in your engagement exercise or process? What are the facilitators' experiences going through the engagement activities? And what can you do to provide participants with value? What can they take away from the experience? How did the participants perceive the engagement experience? Did their experiences of the engagement match the goals you had for the engagement? And what are action items and future opportunities for collaboration? So at the end of this stage, you've completed your initial engagement exercise or process, and you've got a preliminary understanding of the population's perspectives, as well as hopefully some opportunities for improvement in future or ongoing engagement. In step 5, you're using the feedback that you've solicited from your engagement process. And so reflecting on, what are the key findings? How do these opportunities connect with your strategic priorities, or have you developed new priorities or initiatives that have emerged from the work? How can these findings be integrated into your work? And what's the impact of integrating these findings into your work? So you'll have, at the end of this stage, considered and used the feedback that you got from the engagement process to inform future work. And number 6, communicate and evaluate the impact. So what has been learned from the engagement experience? What were the intended or unintended consequences of engagement? What were the predicted outcomes? What were the actual findings? And how can these results be best disseminated to stakeholders, but also to the equity deserving populations that you're aiming to serve ultimately? And so I'd encourage you to take a look at that framework if that sounds like it might be useful for you. We talked about some different forms of engagement, and so I want to just highlight, there are kind of broad strokes, continuous types of engagement or more ad hoc approaches, and they can meet different needs. And so to select the most appropriate approach for engagement, your team really needs to develop a clear understanding of the purpose of engagement and collaboration with your partners. So in a continued engagement structure, that might be something like an advisory panel or advisory team, council, or a working group where you've got ongoing engagement with the same individuals or groups. And there's a greater opportunity in this form to tackle more complex problems and get more detailed feedback. It's a very respectful way to engage because you build a relationship with folks, and it's a longer term commitment, but does offer a smaller sample size, and it can take time to build rapport and to foster participation, and certainly human resources as well. There are other forms of more ad hoc approaches to engagement. And so those might be things like a one-time engagement exercise, inviting members of the community to a workshop. Could be something like a survey, like the Sex Now survey that we've got out serving the queer Canadian public. And this offers a larger sample size, and so potential for more diverse inclusion of different identities that you might not have access to in a continued engagement approach. Maybe less resource intensive, depending on the size and scope. It probably works better for more simple or well-defined questions or problems. And sometimes a combination of these techniques is the best solution. So talking about our research program and our engagement strategy, to start with, we, as I mentioned, established this collaborative group of co-investigators and collaborators who had themselves diverse sexual orientations and gender identities, as well as expertise. Started our work with some literature review and expert discussion, and then we were able to partner with a community-based queer research advocacy organization. And so actually 2 large community-based queer research advocacy organizations in Canada have been really helpful and central in connecting us and helping to guide our engagement approach. And so for our research program, we engage with EGAL Canada and with the Community-Based Research Center. And so these are both research advocacy organizations that have their own experience engaging with queer communities and representing the interests of queer communities and interfacing with health systems. And so those organizations, I would recommend, folks thinking about, with whatever population that you're looking to engage with, are there existing community-based organizations that already have connections in this community? Because they can really be very meaningful partners. And so we concomitantly were developing this research program, and through some of this initial work, we were able to get the support needed to build the advisory team. And so these are the folks that I mentioned with lived experience and queer identities in the organ and tissue donation and transplantation system. Our recruitment approach started with an open call for that advisory team. So we sent out letters to caregivers of deceased organ donors who had been registered with our organ donation organization, as well as living transplant recipients. And it ended up turning into a snowball approach. There were a few people in Manitoba, but we're relatively small population compared to some other programs. And so we ended up with an international group of people across Canada and the US who we were able to reach through this type of sampling to join the advisory team. We needed support and funding to support this advisory team. And so we received our initial funding from a small patient engagement grant, not to diminish its impact, but relatively smaller grants. And that was the Preparing for Patient Engagement and Research, the PrEP award that the Center for Healthcare Innovation at the University of Manitoba offers every year. And so this gave us the seed funding to be able to conduct our initial engagement exercises and form that team and to remunerate those patient partners for their time and sharing their lived experience. And then that allowed us to build subsequent funding applications into larger grant applications and to more durably support engagement with some larger awards. We were also really lucky, and I have to give a shout out to the Manitoba Spore Support Unit, who have been so generous in providing professional facilitators and engaging with us around planning for our engagement and running our engagement advisory team meetings, which has been a really excellent strength. So if you've got a local spore support unit and you're planning for engagement, I would advise, without question, consulting with them to understand what kind of support they can offer, because it's a very high yield activity. And we've incorporated our advisory team as co-creators and collaborators on all of the work that we're doing. So a couple of things I think just to reflect on, thinking about your own research program, if you're planning for engagement or if you already have engagement structured into it, thinking about what population that you have or that you would like to engage with to inform your research. Is this population an equity deserving population, or are there key equity deserving subpopulations within that you might want to include? And how would you go about recruiting members from this group? And so before we open for more discussion and question, just in very brief, I'd like to kind of end by talking a little bit about health policy revision as a research program goal in this patient-oriented program of research. So we identified early on that there were many policies and practices in the OTDT system that were inequitable and that we argue are not data-driven. And really the overarching goal of our research program, as informed by our patient partners, is equitable policy revision. The goal of this research is to see that policies that we feel are restrictive or discriminatory or stigmatizing, are corrected where they can be. And to achieve this, we made an engagement plan both for impacted populations and key stakeholder organizations and decision makers, and had some success. Knock on wood whenever you say something like that, but I think we're making great strides in a very short amount of time to be able to achieve our goals. And I really have to credit this to our patient engagement approach as well as our stakeholder engagement approach. So I'll talk a little bit more about that. We've planned both academic output, so scientific papers published in peer-reviewed journals, kind of the traditional sense of what scholarly production is, but also public-facing and stakeholder-facing work that is, I think equally, if not even maybe more important. So thinking about the OTDT system in Canada, it's regulated by Health Canada as an organization, but there are a few different bodies that are stakeholders. The standards that are applied are defined by the Canadian Standards Association, and so that's its own specific group. And then each provincial program across Canada develops its own policies through their organ donation, transplantation, and tissue donation health service delivery organizations. But these policies all have to meet those Canadian Standards Association standards in order to be accredited, or for those programs to be accredited. And so there's this kind of feedback interaction with the federal, national level organizations, as well as the provincial level organizations. And then Canadian Blood Services and Hema-Quebec are the organizations that operate the system. And so these are all folks that were critical as stakeholders and decision makers to engage with early on. And their feedback has been incredibly important also in guiding the type of work that we're doing, because this group is able to tell us, that this is the evidence that we require to inform equitable policy revision. And so bringing both of these groups together through planned engagement has really supported and facilitated the program. And so as I presented previously to you, that one of the next steps that we have coming up is a national consensus process. Before we were able to bring all of these people to the table, we needed to get the attention of system stakeholders. And so, reflecting, I think, for myself on how we were able to achieve this, being an insider is a critical, I think, element. And so myself working within the system, working with these organizations, is a level of relationship building that an external researcher just wouldn't have access to. And so considering who are the insiders and who are the key stakeholders and decision makers for your engagement in order to inform equitable policy revision is really critical. And then we also had sort of a stage level of engagement with these partner organizations and research networks. We published a few sort of public-facing pieces that included some of our initial scoping systematic reviews, this health policy critique that I mentioned, as well as some other narrative reviews. And part of the health policy publication was a media engagement strategy, which as a clinician and an academic was new to me, but was highly effective in having uptake of some of our work into the media. And so our stories, were picked up by national news organizations. And then that really brought a lot of stakeholder, institutional, and organizational awareness, which I think got people's attention. And so we were immediately kind of recognized as working on this problem and having the research program defined as an issue. And that, I think, really facilitated that institutional and stakeholder engagement. And really, ultimately, at the highest level, our health system is funded and priorities are set by the government. And the government responds to public attention. And so with respect to blood, cells, organs, and tissue donation, it's really important to engage the government and understand their perspectives, what their needs are, and what level of evidence they require to inform equitable policy revision. And so in our case, there's already an existing template for policy revision in that the blood donation system, which is connected but separate from organ and tissue donation regulation in Canada, recently saw changes to their eligibility criteria that were kind of along the same lines. So moving away from gendered, sexual orientation-based questions to questions that were gender neutral and really specifically focus on evidence-based behaviors that increase the risk of transmission of HIV or viral hepatitis, which is the safety concern. And so we were able to collaborate with key players from that process to share knowledge and benefit from lessons that they learned and understand the risk tolerance profile and motivations of decision makers in the system so that we could target some of our work to address those needs. And so I think for further reflection, some other questions I would ask you to consider for yourself are, who are the relevant stakeholders and decision makers in your area? How might you engage with them? What are the relevant barriers or facilitators to engaging with them? And what are the motivations and needs of those decision makers? So that's a bit of a rapid overview, but I'm happy to open up the floor for any questions, comments, shared experience, reflections on some of those questions that I've asked. Thanks for your time and attention today.
Thank you so much, Dr. Lees. I will go ahead and stop the recording and take a moment to give the participants their permissions back, and then we'll get to that question period.